Welcome to Clean Med KE, where we make clinical medicine and surgery clear, structured, and clinical. Today, we are diving into the master map of antithrombotic pharmacology. Disclaimer: this video is for educational purposes only and does not constitute medical advice. To understand blood thinners, we first have to understand how the body stops bleeding. We divide this into primary hemostasis, which forms the white clot primarily through platelet aggregation, and secondary hemostasis, which creates the red clot using a fibrin mesh. In clinical practice, remember this pro tip. Primary hemostasis issues usually cause superficial bleeding, like petechiae, while secondary hemostasis issues lead to deep tissue bleeding, such as hematomas or joint bleeds. We target the white clot with antiplatelet drugs and the red clot with anticoagulant drugs. Think of the coagulation cascade as a funnel. On the left, we have the intrinsic pathway, triggered by internal trauma like exposed collagen. It's the longer pathway and is monitored by aPTT. On the right is the extrinsic pathway, triggered by external trauma and tissue factor. It's shorter and monitored by PT/INR. Both meet at the common pathway, factor X, which eventually converts prothrombin to thrombin and fibrinogen to that stable fibrin mesh. As we can see, warfarin acts on the extrinsic side, while heparin primarily targets the common and intrinsic pathways. Let's look at our tools for preventing that white clot in fast-moving arterial blood, which is crucial for managing stents, strokes, and STEMIs. Aspirin works by blocking the COX-1 receptor, preventing the conversion of arachidonic acid to thromboxane A2. We also have P2Y12 ADP receptor blockers like Clopidogrel and ticagrelor, and GP2B3A inhibitors like Abciximab, which prevent fibrinogen from cross-linking multiple platelets. Finally, drugs like dipyridamole work as PDE inhibitors, increasing CAMP to inhibit platelet activation and cause vasodilation. Now let's move to anticoagulants, starting with unfractionated heparin, or UFH. This is our heavyweight because it's a long chain that accelerates antithrombin 3, allowing it to neutralize both factor Xa and thrombin, factor 2. Because it has a rapid onset and a short half-life, it's ideal for acute emergencies like pulmonary embolisms or MIs. We administer it via IV drip and must monitor it strictly using aPTT, aiming for 1.5 to 2.5 times the normal limit. In contrast, low molecular weight heparin, like enoxaparin, and Fondaparinux are precision tools. Their shorter chains primarily target factor Xa. These are great for outpatient bridging because they have a predictable response and don't require routine aPTT monitoring, though if you must monitor, you'd use an anti-Xa assay. One major caution: these are cleared by the kidneys, so avoid them in patients with severe renal failure, where the GFR is less than 30. To summarize the heparin matrix, UFH targets 2A and 10A, is safe in kidney failure due to hepatic clearance, and is fully reversed by protamine. LMWH is more selective for factor Xa, requires no routine monitoring, but carries a risk in renal failure, and is only partially reversed by protamine. LMWH also carries a lower risk of heparin-induced thrombocytopenia. Switching gears to warfarin, our oral mainstay. It works by throwing a wrench into the vitamin K epoxide reductase cycle, which effectively starves the production of vitamin K-dependent factors, 2, 7, 9, 10, and proteins C and S. We monitor this using PT/INR, usually targeting a range of 2.0 to 3.0. A critical warning: warfarin is highly teratogenic. It crosses the placenta and declares war on the baby, so it must never be used in pregnancy.
Why do we bridge patients with heparin when starting warfarin? On days 2 through 5 of therapy, warfarin actually inhibits the natural anticoagulants, protein C and S, before it inhibits the procoagulant factors. This creates a temporary procoagulant state where clotting risk is actually increased. We use a heparin bridge to keep the patient in the safe zone and prevent complications like warfarin-induced skin necrosis.
This table highlights the heavyweight showdown. Heparin is rapid, short-acting, and safe in pregnancy, while warfarin is slow to start, long-acting, and teratogenic. Remember, heparin uses the intrinsic pathway, and warfarin uses the extrinsic pathway. We must watch for HIT, a severe immune complication. It occurs when heparin binds with platelet factor 4, PF4, creating a complex that triggers IgG antibodies. These antibodies activate platelets, causing widespread thrombosis, clotting, and a subsequent drop in platelet count as they are consumed. Action plan: stop all heparin immediately. Do not give LMWH, and switch to a direct thrombin inhibitor, like argatroban. Safety is paramount. Patients must be taught to recognize signs of bleeding, sudden severe headaches, nosebleeds, coffee ground emesis, dark tarry stools, or reddish urine. We advise patients to use electric razors and soft bristled toothbrushes, and they should never take NSAIDs or aspirin concurrently without strict medical approval. When toxicity occurs, we reach for our antidote kits. For heparin, we use protamine sulfate. For non-emergent warfarin toxicity, we use vitamin K, though it takes up to 24 hours to work. In cases of severe hemorrhage on warfarin, we need immediate rescue with fresh frozen plasma, FFP, or prothrombin complex concentrate, PCC, to instantly replenish clotting factors. Finally, here is our master map. We prevent the plug with antiplatelets like aspirin. We prevent the mesh with anticoagulants like heparin, warfarin, and the newer direct XA inhibitors. Crucially, remember that these two classes only prevent clots. Only fibrinolytics, the clot busters like TPA, actively break down an existing clot. If you found this helpful, please like the video and save it for your rotations and share it with your study group. Subscribe to CleanMed KE for more high-yield, clear, and structured medical breakdowns. See you in the next one.